Hi, I'm Becky Pearce, paediatric physiotherapist, working in Hampshire. I've done a few information videos for UKIST in the past, which I've heard have been quite helpful. There is a series of development of movement which may be worth looking at if you find this session helpful, because that video goes into a little bit more detail about some of the things we'll be talking about today, and give some practical tips and ideas for developing strength and stability. So that might be worth doing. So in a recent Q&A session hosted by UKIST, I received quite a number of questions relating to extensor thrust and how to manage it. And it did appear that this is quite a common concern in the UKIST community. So we thought it might be helpful to put together a small video focused solely on this topic. So here we go. So an extensor thrust in neurological terms describes a total body movement pattern which causes the head, the trunk and the limbs to extend, which throws the child backwards. And this can vary hugely from just sort of a very brief backward push to a very strong and sometimes prolonged and painful spasm. This extensor thrust patterning, as we call it, can be involuntary, meaning that the child has no control over this movement, or it can be a purposeful behavioural response. And both reasons for extensor thrust can cause significant difficulties to development of movement and function. And if your child is experiencing very strong or very frequent extensor patterning, to the extent that is preventing development of movement, it is probably worth speaking to your paediatrician or neurologist just to discuss options of medication, which might help managing this muscle tone. So extensor patterning can be a particular problem for children with fluctuating muscle tone or dystonia, as they are battling to overcome lack of stability caused by their fluctuating, changing muscle tone. Also, children with spasticity, so increased tone, can experience extensor patterning, and that can be a result of sort of overflow of muscle activity because their muscles are more excitable to a stimuli. I have actually seen extensor patterning in children with very low muscle tone, and they use that sort of extensor thrust to try and recruit strength and muscle activity when they've actually got underlying weakness and hypertonia. And very importantly, extensor thrust is also seen in children who have difficulty with sensory modulation. So this can be a behavioural response to fear, to distress, to anger, as well as excitement and pleasure. So that's quite relevant in our little talk today. So today's session will hopefully give you some ideas as how to reduce the frequency and the severity of the extensor thrust, and give you practical ways to avoid a child's tendency to use this patterning. As I say in all my presentations, every child is different and will respond differently to different stimuli and handling techniques. So this isn't really a recipe for all, but I do hope that you can use some of the ideas and concepts to help your child with their specific problems. So first of all, I think it helps to understand, to talk about what is actually happening throughout the body when a child is having an extensor thrust. And considering the movements used during extensor thrust will help you identify ways of reducing the child's tendency to push backwards. And we discourage this extension sometimes by talking about breaking up that pattern, so that pattern of extension, and you can influence muscle tone by breaking up the pattern. So if we just think about what the child tends to be doing, so we'll start off with the head. So when a child does an extensor thrust, they tend to throw their head backwards. This is rarely seen in the midline. It's very often a rotational movement. So you might find that they just rotate off to the side and then throw their heads backwards. So that's what's happening in the head. An extension of the neck often associated with a rotation as well. In the arms, you see that the shoulder generally is pulled backwards into extension. And you see often an internal rotation at the shoulder joint with an extended elbow and what we call a pronated forearm. So that position. So it's that pattern that we tend to see, but it's going behind, so you can see it better. That's kind of what we see. We do often see fisting in the hand, which is actually a position of flexion, but it's all part of the extensor patterning. That is what we're seeing. In the legs, you tend to see an extension of the hips. And when this happens, the hips themselves tend to rotate inwards and scissor together. I have got my doll here, which might be a better demonstration. So you get an extension of the hips, and at the same time, adduction and internal rotation. So that is what is happening in the hips. They tend to come together and scissor with internal rotation and extension of the hips. You see that the knees extend, and very often you see that the toes will point into what we call plantar flexion. So that's head, arms, legs, and the trunk itself will extend and arch backwards. So just considering these different patterns of movement when we talk about breaking up tone. So when your child is pushing into extension, you can often discourage this by placing them in a position which lessens their tendency to thrust by taking away one of those key movements, which is very often the head position and the hips, because they're very strong stimulators of an extensor thrust. So we will talk a bit more in detail about influencing this extensor pattern using head and trunk, hips. Before I show you how to handle and position your child to break up this tone and patterning, it's important to look at a key piece of information in this scenario, which is why is the child doing this? And this is really important. It's actually something that as parents, it may be difficult to spot, and it is something that physiotherapists do, is look at why a child might be extending, and then we can adapt what the child is doing to prevent the extension. But I think it's really helpful for you to understand as parents what we as physios are looking for, because it might give you some clues as to why you're struggling to get your child into a certain position. So I think the easiest way for me to explain this scenario is to take you through something that might be familiar to you. And this was one of the questions that came up in the Q&A. Was somebody said, when I placed my child sitting on the floor, because the physios told me I need to work on sitting balance, and they immediately just push back into extension. So in this scenario, I would be thinking, if I had a child that was pushing backwards, I would be thinking to myself, is this child ready to be put in a sitting position? Is the child comfortable in that sitting position? Does the child feel safe and secure in that sitting position? And what am I actually asking that child to do in that position? Is the function that they're trying to achieve in sitting something that they can? Is it achievable, or is it actually too difficult? So if the answer to any of these questions is no, then we need to adapt the position to make the position achievable, to make it comfortable, to make it safe, and make it a position where the child is happy, enjoying themselves, and successful in any task that they're trying to achieve. So for the example of sitting, thinking about, is the child ready for sitting? So if a child is sitting, they need to have some degree of head control, some trunk control. They need flexibility at their hips to be able to, if we're talking about ring sitting on the floor, to be able to rotate their hips out and get that nice big base of support ready for stability. And they will develop all these skills needed for sitting, from lying on their tummy and lying on their backs, which again goes into more detail in the other videos. But they'll achieve those skills before they are ready to sit up. So you just need to consider, if you are sitting your child up, are they ready? Even as sitting with support, they need some of those elements. So if a child is missing any one of those key areas, they are unlikely to be comfortable or feel safe in this position, and they may well use a behavioural response and extensor thrust to get out of it. So I'm going to move over here and do a little bit more practical demonstration for you on the doll, looking at various scenarios that were brought up, and give you some practical tips as to what we can do to help. So I'll just move around. hopefully you will be able to see me and my baby. Move back a little bit. Excellent. Right, so if we think about sitting, so as I've said, supported sitting on the floor, a child needs to have some degree of head control, trunk control, mobility at hips to be able to, if ring sitting, sort of spread hips out and get that nice stable base, and also have some extension of their spine, so to be able to sit up. So any of those elements missing, we need to adapt the position to stop the probability of that extensor thrust, because they're either using an extensor thrust to help bring their head up because they haven't got the head control, so they might see some overflow of bringing that head up. They might be uncomfortable, that's why they're thrusting back, or they're just not happy and feel vulnerable in that position, so using an extensor thrust. So if you think about head control and trunk control, if a child hasn't got enough head control or trunk control to sit, we need to think about, okay, we need to adapt this position to provide them with more stability. So there's many ways you can do that just by handling and having your hands in the right place. So if you're holding your child down at their hips and they're tending to push backwards, you might want to move your hands a little bit further up. So giving them support around their chest area. That makes them feel more secure, gives them more stability in their trunk to be able to balance their head. So just moving your hands up can help. Sometimes you actually have to put hands on shoulders to provide them with a stability to be able to lift their head up. So just think about your handling. Is it something you can do with your hands just to move from lower down the body where they might push backwards to give them a bit more support at their chest or at their shoulders? So it doesn't have to be your hands. You can think about using cushions, the famous V cushion, just providing extra support with cushioning. Just makes the child feel more secure, less likely to use that thrust because you've given them that support around their trunk and some support to help their head control. Also think if you're putting them in a chair, think about the chair. Maybe you need to adapt the seating that they're actually in. If it's in a little unsupportive high chair, for instance, perhaps you need to put in a few cushions or use the straps that are there just to make the child feel more secure and more stable. So you just think about adapting that position if it is a case that they haven't got quite the control in their head and trunk for sitting. Another thing you can do when a child is quite flexed and they haven't got enough extension in their trunk to be able to sit, they may use that extensor thrust to try and push up backwards. So what you can do is sit the child on a little wedge, and that will just tilt the pelvis forward. A bit difficult to show my baby, but it will tilt the pelvis forward and allow them to use more extension in their spine. So just sitting on a little cushion or a little wedge might just give them a little bit more extension in their spine, so they can do that voluntary rather than using extensor thrust to really recruit that extra muscle activity. So that's something you can do if they're quite flexed in sitting. Also, we talked about hip mobility. You need to, for ring sitting, you need to be able to externally rotate your hips and abduct your hips, which is that position I'm talking about. So you need to do that and have a nice base of support. If your child's got quite tight hips and can't do that, you can see that there's a very narrow base there, and the child will probably feel quite vulnerable, and then behaviourally may use the extensor thrust because they don't feel happy and comfortable and stable. So again, we think about adapting the position. So what I might do is take the child off the floor and up maybe into 90-90 sitting. So they can have feet on the floor, and actually their hips are in a completely different position here. They're not externally rotated and they're not abducted. You can see that knees are quite relatively close together, but they've got the stability from the floor, but it's taken away that problem at their hips, and you might find they sit a lot better in that position than in floor sitting. And you can still work on head control and trunk control in that position, but you've just taken the problematic area of hips away. We talk about, I did mention breaking up the pattern, about taking away one of those key elements of the extensor thrust to reduce the child's tendency to use it. So we talked about at the hips, so when the child uses an extensor thrust, the hips extend, internally rotate, and adduct and scissor together. So we want to think, we've adapted the position a little bit, but maybe there's still a tendency to over thrust and use the extensor thrust. So we might want to break up that pattern by giving them more hip flexion. So maybe sitting them between your knees, so you can see there the child is very flexed at their hips, and that might just stop the ability of using that extensor thrust if they're in a really bent position there. And also a little bit of knee flexion as well, because remember, extensor thrust is tendency for knee extension, legs straight. So if you've got bent knees and bent hips, the child may feel more comfortable and less able to push into that extension. So that's something I do there. Another way of breaking up the pattern, so not adapting the position so much, but thinking about breaking up the tendency to use the thrust, is to use straddle sitting, which physios often use, because you can see here the hips, we're breaking up that scissoring pattern. So if the child's hips are what we call abducted, so wider apart, you would want to get a little bit of knee flexion if you could, again breaking up that pattern, and just sitting in that position can be enough to stop the child thrusting themselves backwards, because you've broken up that pattern at the hips. You've got a bit of flexion and you've got that abduction, so knees apart, and that can be a really good one to help break up the tone. Another way of breaking up the tone, I said a key point is the head. So if a child is having difficulty lifting their head up and they're triggering their extensor pattern by extending their head up, just preventing that extension by encouraging a little bit of chin tuck. So again, sitting in this position, you've got the hip flexion, we're breaking up the tone there. We've got knee flexion, bent knees, breaking up the tone there. And just with a little arm here, keeping the chin tucked forwards, again, is another way, what we call breaking up the pattern and discouraging that thrusting backwards. So chin tuck control can be really helpful, just in the crook of your arm, because again, you can stop that rotational element as well. You can keep head in the middle and a little bit of chin tuck. So those are ways of breaking up the pattern, and also ideas for adapting the position if your child's using that thrust. So that is sitting. Thinking about a more sort of from a sensory perspective here, for sitting, if what you're asking the child to do in sitting is quite sensory overwhelming, that can be a trigger in itself to thrust backward into extension. So as well as considering head position, so you don't want to put something way up high that the child is having to lift their head up to look, because that might trigger a pattern. Make sure you're putting something at the right level in front of them so that they can tuck their chin in and look down, not have to look up, which may set them off into extension. So something a little bit lower down, chin tuck, and also something that's not too overwhelming from a sensory point of view. If there's something really bright, flashing lights or loud and noisy, that can be enough to trigger a sensory response from actually what you're asking to do. So it's nothing to do with the sitting position, it's what you're asking them to do in that position. Also, from a fine motor point of view, you don't want to provide them with an activity that involves a lot of intricate fine motor function, or something that's quite big and heavy that they're trying to grasp and carve, because often the effort of doing something that isn't actually achievable at their level can again trigger an extensor thrust. So make sure the toys you're providing them, if they're wanting to play and grab at things, that they're lightweight, they can get their fingers into and lift and hold and play with, so that it's successful in their play. And if they're enjoying play, they're successful in their play, then you won't see that extensor thrust quite so much. So those are just a few other things to think about in sitting. So it's head position, not looking up, not too much sensory stimulation, and make that activity something successful and achievable. So there's lots of different things to think about with one position. I can't tell you which is the trigger for your child, but hopefully looking at the bigger picture, you can pick out little things that you might be able to use to adapt a position. So another scenario we were given was bathing, so bath time. Whenever I put my child in the bath, they really extend back. Now, if we think about the whole process of bath time, that is a massive sensory overload of information. So if a child has difficulty with sensory modulation, there are so many different things there we need to think about, as well as the handling of the child and adapting the position. So bath time, you're undressing the child, so you're taking their clothes off, so much sensory information there, temperature, touch, body movement in space, that might be quite overwhelming. So then you're actually going to take your child, lift them up, so that movement in space is quite massive if a child has quite a lot of sensitivity to movement in space, and then you're putting them down in the bath. If a child has been used to being held quite close to you and have a lot of support, just that movement can be enough to trigger an extensor thrust. So just consider how you're doing it, keep the child close to you, reduce the amount of movement in space that they're experiencing, so it's not too overwhelming. Obviously, getting into the water, you've got the temperature of the water. If the water's, even if it's not too hot or too cold, simply having the warm water around you is enough to trigger an extensor thrust. Also, noises in the bathroom. Bathrooms can be quite bright because you have bright lights, and quite echoey. A lot of noise from the water flowing. You might have an extractor fan going on in the background. A lot of noise, a lot of light. Just a huge amount of sensory information coming in. So if you find that bath time is a trigger for your child and they really are pushing back, try and modulate that activity. Try and break down the chain. So you're doing things much more slowly, and considering all the different changes that are happening. So reduce the sensory information if you can, and limit all that information that's coming in, and just do it very slowly if you can. So that's bath time is quite a sensory trigger. So yeah, that was quite a good one that came out and quite useful to explain. Also, feeding came up a lot when you put your child in a high chair to try and feed. That's when they start thrusting. Again, considering the sensory side of feeding. So you've got that actual taste and texture of food, moving food around the mouth, chewing, swallowing, a lot of things going on there. So that's going to leave a child slightly vulnerable to, if they are thrusters, then that might trigger an extensor thrust. High chairs as well are not particularly supportive. They sometimes have little foot plates because we often, we think it's really nice to have a child sitting at 90-90 for stability. So have flat feet, bent knees, and a nice stable position for eating. But actually, a child who tends to thrust, if their feet are on a surface, they might thrust backwards. Also, the high chairs tend to be wipeable, so they're quite slippy. So children can slip down in the high chair. Their feet are on this foot plate, and that's a beautiful position for an extensor thrust. So in the high chair, some of them have pommels, which are great because they try and keep the hips back, which is nice. You might want to take the foot plate off if that's a trigger for your child. Just have them have their feet dangling a little bit if that helps them. It might do the opposite for some children, but others it might help. So a pommel, and sometimes they have a little waist strap, so if you can do the waist strap up to keep the pelvis back and secure, so they're not going to do that slipping, which allows a little bit of hip extension. And you can put little cushions and things in around also to try and keep the weight forward so that the child can't extend backwards. So with feeding, again, you're in the kitchen. Kitchen's a busy place. You might have a washing machine on, you might have the dogs in there, the telly on, the microwave pinging, the lights. It's a really intense environment to take the child into. So think about all those things which may well trigger that extensor thrust. That was feeding as well. Another scenario we had was standing. Whenever I stand my child up, they push up, so they tend to push up on tippy toes, lock knees, and go really stiff in standing. What can we do about that? So I would think, be looking at the child again and saying, is this child ready to stand? So for standing, you need to have strength in your legs, stability around your hips. You need trunk control and head control just to maintain even supported standing, or standing, talking about standing at a surface. So has your child got what it takes to be able to comfortably maintain that position? What I would do with a child who tends to go quite stiff in standing, I do a lot of preparatory work before I just go into standing. So what you might find helpful is I do quite a bit of 90-90 sitting, which is feet flat on the floor, knees bent. So I'm putting pressure down through the child's knees and just getting them used to having weight going through their feet, because sometimes just having that sensory information going through the bottom of their feet is enough to trigger a thrust. So just getting them used to having their feet on the floor, gradually increasing the pressure. Also think about that floor surface you're standing on. Is it prickly? Is it cold? Is that going to trigger a response? Think about footwear. Some children love having shoes on and are less sensitive if they've got shoes on. Some hate having shoes on, are better barefoot. So just consider which might be the case in your child if that's a problem with sensation to the bottom of the feet. But I would always start with a little bit of 90-90 sitting, pressure through the knees. Now, a lot of children, as soon as they feel their feet on the floor, to go into standing, they push up backwards. So they go side on. So you've got the feet flat. So they will stand up by doing that. We don't want that. That is a complete extensor patterning, which we want to really discourage. So I always encourage children, if they've got feet flat, you want nose over knees. So if you can get your child to lean right the way forward and then stand up, that's a much more normal movement pattern. And you're really working those glutes and those quads independently from the mass extension pattern, which is much more useful and more functional. So gentle weight through the knees, flat feet, and then nose over knees and coming up into standing. You're less likely to see that extensor thrust then. Once they're up into standing with feet flat, what I tend to do to start with is just a little bit support around the hips and just a little bit of rocking from side to side. So if you're changing the weight bearing from one side to the other, it's more difficult to get that patterning of extensor thrust. So just rocking from side to side, get them used to weight bearing from a sensory point of view, and just stopping, triggering that tone can be really, really helpful. Sometimes a little bend in the knee and straighten up, bend in the knee and straighten up, just to get them used to standing without using that extensor thrust. You can sometimes just increase their base of support. Again, like we said in sitting, by hips coming out into abduction, it's more difficult to recruit that extensor patterning. So just keeping their legs, or just something between their legs a little bit, can stop that patterning. That's often helps just to reduce their tendency to thrust backwards. And then usually when they're up in that position and you've settled them with feet flat, leaning forward a little bit, not a lot, can just stop the tendency to do the thrust. That's what I would do with standing. So I think we've covered most of the scenarios that we had in the Q&A session. So it was sitting, my child pushes backwards, bath time, feeding, and standing for the scenarios we had. So I hope I've covered those scenarios for you. I was very briefly just going to talk about if you've got a child who isn't quite at that level, and is still doing tummy time and back lying, and you find that in back lying they're really arching, and in tummy lying they're tending to do the sort of skydive position, so head and legs come up. So really that's quite a strong extensor patterning that you're seeing. I just thought I'd give you a few pointers as to how you can reduce that from happening. So in tummy lying, to be able to lie on your tummy, you need to be able to comfortably, you need to be able to clear your head, lift your head, prop through your arms, and you need to have quite good stability at your pelvis to bring your weight backwards to allow you to lift your head. So that's kind of the position you want to be able to achieve to comfortably lie in prone. If you're missing any of those skills, again, you might see this extensor patterning, trying to lift head up, but trying so hard that their children are using that mass pattern. So I think, first of all, we need to think about if they haven't got enough head control, we need to adapt the position to make it easier for the child to lift their head. So the easiest thing to do is use an incline. Okay, so using your lap, using a wedge, using a therapy ball, all sorts of ways just to bring that your child up so that gravity is working hard there. If you're at an incline, obviously you've got less gravity affecting your movement, and it's easier to lift your head. So you can actually have quite a high incline over your shoulder. That's still prone lying, but just reducing the effort involved, adapting the position to allow the child to successfully lift their head without using an extensor pattern. From a shoulder prop point of view, we can use just a rolled up towel. So if the child's on the floor and can't prop through their shoulders, just using a little rolled up towel underneath their chest can sometimes be enough to allow that shoulder prop position. And when they're in that shoulder prop position, it's easier to lift head. Okay, so that's just allowing propping through the shoulder girdle and the head extension. It's a nice thing to do. Another thing that is quite useful if a child is finding it hard to lift their head up is just to put a little bit of pressure down on their bottom. So by doing that, you are taking the weight-bearing surface further back towards their feet, which makes it a lot easier to lift head up. So just a little bit of weight going through the lower part of their back, the lower part of the pelvis can just stabilize the pelvis and allow a more comfortable position, and you'll see less of that extensor thrusting. If your child is still using a lot of tone extensor thrust, so we're probably looking at the children, young children who have a very high muscle tone, what I would then do, because obviously tummy line, you've got that extension at your hip, and that, like we said before, that is a key point for control. So what I might actually do, if I want to work on head control, is just bring them up into a kneeling position with perhaps a bit of support in front of them here. So although this is kneeling, it's still working on head control and working on all the skills you need in tummy lying. But by bending the hips up and bending the knees, you've broken that pattern and made it a lot more difficult for your child to use that sort of skydiving position. And it may be that in that position, they're able to work on that head control. So just a few ideas. If your child is tummy lying and really using an extensor arch, those are ways that you can adapt the position to make it more difficult for them to use the extensor thrust and more successful. Okay, and just last of all, we'll just cover supine lying, so back lying. So some children with a lot of tone, using a lot of extensor spasm, might you see this arching. So sometimes from the back of their head to the heels, using that extensor thrust. So we want to break up that tone and adapt the position. So for a child to lie comfortably on their back, they need to be able to hold their head in midline, and they need to move their arms and their legs up against gravity, and then that will be a successful position. So if the child can't do those, we need to adapt the position to make it easier for them to do it. So a key point of control, as we said, is the head, so that extension of the neck. So what I would do is just pop a little cushion behind them, and you can immediately see you've got that chin tuck position. So it's much harder to do that extensor spasm if your head is tucked in. So this lovely V cushion, we've got that lovely chin tuck, but also the V cushion, you can see, brings the arms forward and takes away a bit of the effort of moving arms against gravity as well, which is lovely. You've still got a fair bit of extension going on at the hips there, so you can just use another cushion underneath the bottom. So you've got a lovely little nested position there, so you've got more hip flexion, little bit of knee flexion, so knee bend, hip bend, and that makes it with your chin tuck and your arms forward. So if you've got a child who's really pushing backwards, using this lovely nested position is breaking up that big movement pattern of extension by bringing the child into a little ball and making it easier for them to move in that position and reduce the tendency for that extensor thrust. So I hope that's given you a few ideas if your child is thrusting, and just some pointers as to so you can look at the scenarios and think, why is this happening? That's really important. Obviously ask your physio if you're struggling, and they can give you specific ideas, but as a parent it can also, hopefully this will allow you to have a look and know things that you can do to perhaps make your child more tolerant of certain positions. So I hope that was helpful, and like I said, if you want to look at movement in a little bit more detail, those development of movement videos might be helpful. Thank you.